Dr. Sandeep Kumar. So Dr. Sandeep Kumar will be presenting a case on reperfusion of choriocapillaris in the case of CRVO combined with cilio-retinal artery occlusion.
A very good morning to you all. I'll be discussing a case of reperfusion of choriocapillaris in case of CRVO combined with cilio-retinal artery occlusion. An 80-year-old diabetic and hypertensive male presented to us with on-off history of transient blurring of vision in right eye for 4 weeks. On examination, there was diffuse increased tortuosity and venous dilation. There were retinal hemorrhages in all quadrants. The left eye was within normal limits. Scans were normal on that presentation, so we advised a full cardiac checkup, carotid Doppler, close follow-up, but the patient didn't get it and presented to us within next 7 days with a drop in vision to 6/60. I apologize for the absence of color photo because there was some technical failure that day. So this is a 15/9 octa image, superficial slab, which shows a lot of CNP areas, tortuosity, and probable CME here. The region supplied by cilio-retinal artery appears a bit fuzzy, but it still has blood supply. So, but when you take a choriocapillaris slab, you could see the corresponding zone shows a wedge-shaped defect void in flow in the choriocapillaris slab. A B-scan, SD51 scan confirmed the CME, and inner retinal hyperreflectivity confirmed the cilio-retinal artery occlusion. So we started with anti-VEGF, but the patient presented on the 7th day with vision drop to 3 meter, and there was a full-fledged cilio-retinal artery occlusion that day. Left eye was stable at 6/9. We did an angiogram. There was a delayed arm retina span of around 32 seconds. There were blocked fluorescence. There was a lot of CNPs, and there was no flow in the cilio-retinal artery area, even in the late phases. Post 2 weeks, we are following it very closely. Post 2 weeks of the injection, the CME has resolved, but the inner retinal hyperreflectivity suggesting ischemia still persisted. This is after the color photo on the 2 weeks. After 2 weeks of the injection, the cilio-retinal artery area, this hyperreflectivity had become more consolidated. The hemorrhages have resolved, CME had resolved. So this is the patient presented after 6 weeks of injection. We could see how the CNP areas have become more, more defined here. Probable NVEs in the periphery, formation of collaterals at the posterior pole, and the area supplied by cilio-retinal artery, we can see there is a retinal whitening corresponding to the retinal whitening area. It's a non-perfused area. Corresponding area, and on the choriocapillaris slab, you can see that there was a the flow void was becoming less prominent now. And as the pressure was rising up to 31 mm, we suspected NVG and we did tight PRP and asked him to follow up. The patient presented with a history suggestive of transient ischemic attack. So we immediately referred this time for MRA and carotid Doppler, which showed severe stenosis seen at the right carotid bifurcation with around 75 to 80% luminal narrowing. And there was a carotid bulb mixed density plaque at the carotid bulb on the carotid Doppler. So we referred him immediately to the neurophysician. So the points from our case is emerosis fugax, which we take the patients and even the doctors, they take it very lightly at some times, because here he suggested that this is seen at least in 1/3 of the patients of the combined vascular occlusion. They have it sometime before the onset of the constant blood vision. Second thing, SSOCTA we feel can help in localizing the level of the block. So if you see, this is at the time of the first presentation, this is a CRVO presentation, and what we can see, the area supplied by the cilio-retinal artery is still perfused, but at the same visit, the choriocapillaris slab shows there is a wedge-shaped defect which denotes a void in the flow. So what we can, we suggest that the block has been in the ophthalmic artery right before it was before the central retinal artery and this it bifurcates from the ophthalmic artery, so that both of them get involved spontaneously. So, and other thing is the choriocapillaris has not been has been suggested that it is involved in combined vascular occlusion, but in our case, not only it was involved, but it also got reperfused over the period of time. We can debate over this, that it can be because of the retinal whitening area, but if we see the corresponding flow void areas, it was same, and it kept getting better over the time. And it was present even before the white area was present in the ciliary region. The white area, when it came, it is still present at the end of point when the reperfusion was there. So to conclude, the case highlights the use of SSOCT as an important imaging modality for diagnosis and follow-up of a combined vascular occlusion. The excellent documentation of the capillary dropout areas on the wider montage view obviates the need for FFA during follow-ups. SSOCT can help in deciding the level of block. Thank you for your kind attention.
So the patient had emerosis fugax.
Yes, ma'am. For
and
4
then
weeks
he landed
on
up
off,
in
on off.
cilioretinal artery occlusion.
Ma'am, he was having it for 4 weeks, and then he presented to us for that only. We saw everything was fine. We just asked for a cardiac checkup. Come to us, but he was like, "I'm fine. It is happening once in a while, so let it be." And within 7 days of that, he presented with a drop in vision to 660. That time he had a CRVO with full CME, and the cilioretinal artery region was fluffy. It was not that white thing. And when we did, it was shown on the choriocapillaris, there was a wedge-shaped defect that was corresponding to that white region that appeared later. So it was occurring, it was like cilioretinal artery in progress.
Yeah.
That was like.
It was evolving actually.
It was evolving, yes, ma'am.
But are there reports of the cilioretinal artery getting reperfused when it is associated with CRVO?
Yes, ma'am. They have, now there's, with the advent of this OCTA, there have been a lot of reports of this reperfusion. So,
and vision, does the vision significantly improve?
No, vision, it depends. See, there was, we couldn't follow up actually because of this MRA thing. He had a very huge block. I think he went for a stent surgery for that. So we didn't follow up after that. He didn't came back. His left eye was doing fairly well, so he didn't turn up, I think. And it was around, it's 2 years back. Yeah.
The cilioretinal artery reperfuses soon enough. We would expect vision improvement also, just the way we have in CRAO also.
Yeah, it took around 12 weeks to get to the last point, if I may show. This thing, sorry.
So the reperfusion took 3
this
months.
Thing, this last is of like around 3 months.
And the carotid occlusive disease as a etiology for CRVO? Do you think so? Carotid occlusive disease, you said, is the etiology for in this patient.
There was occlusion at both, at the carotid branch, in carotid bulb, and the right carotid artery branching at the point at the bulb.
What Dr. Gayatri is trying to say, in CRVO, there is less or no role for carotid involvement.
Yeah.
So the fact that you investigated itself is surprising, but that you got a positive finding and you could treat is a good thing. However, in CRVO, we generally do not do carotids. We see carotids for CRAO or artery occlusion, central retinal artery, or in this case, you had a cilioretinal artery, or we do it for anterior ischemic optic neuropathies.
Yes, ma'am.
Or ophthalmic artery occlusions.
Yes, ma'am.
But not for venous occlusions is what I think you're trying
Yes,
to
ma'am.
say.
So there's one thing, the amount of ischemia progression, that was, that led us to think like there were carotid development, because the way it was progressing, the ischemia was progressing very fast. And the pressure, there was no NBI at that time when we did the laser and everything. The pressure got controlled. It went to around 20 after like 4 or 6 weeks of the laser. But we ordered that thing so that we don't miss it.
If you have those reasons, there is no harm in doing
and it was very, because we could follow it up very regularly, 7 days on Octa, so we could document. We couldn't do this FFA. Thankfully, we didn't do in a patient of this block. So, and he was an 80-year-old patient. We could not repeat FFA so frequently. So SSA OCTA helped us in this thing.
Whether he was dyslipidemic?
Sorry, ma'am? He was on blood thinners, ma'am. He was hypertensive. He was diabetic, but he was 80-year-old. He was controlled, like 7.5 was his HbA1c. He was said, I can't go beyond this. 7.5 for 80-year-old is fairly, I feel.
It must be a generalized process.
Yes, ma'am. It is like, yeah, it must be. So we couldn't follow up after the
Go to
neurophysician.
the next case now.